Okay, so continuing really on the same similar topic, dovetailing with Ilan's previous talk, we're going to talk more about the face. And I'm grateful to Dr. Abu Hamid for letting me borrow a lot of his pictures from his beautiful book that really illustrates the drawings are really fantastic. And I wanted to use them as part of this talk to illustrate the areas that are particularly important. So the face is an incredibly important place to look in the first trimester, and you're really forced to look at it anyway because you're looking at the nasal bone typically if you're doing a nuchal translucency, so you're already there. And while you're there, you need to really look very carefully at some of the landmarks that we're going to be talking about that we've already talked about to a certain extent. So the perfect nuchal translucency, so to speak, is shown here where you have certainly the nasal bone, you have the palate, and the intracranial lucency, which is really the fourth ventricle right here. And you can see these areas also on the schematic next to it. This is really the minimum that you should do as far as looking at the face in profile. You've got the chin there, you've got the forehead, the relationship between the forehead and the chin, and so forth. So let's look at the nasal bone. A little bit more detail here. Here is a fetus without a nasal bone, and you can see the nasal bone is that equal sign, and it's really not, this is not the nasal bone, this is just the surface of the skin. The nasal bone has to be underneath that surface, and so do not be fooled. And if you really can't get this view, you can always look at the nasal bone this way. This is the triangle that we've been talking about, the maxillary triangle. And the top of it are the two paired nasal bones that you can see right here. So here you've got the maxillary triangle. Again, you can see it here. It shows you the nasal bone up here, and it shows you the lenses of the eyes, as Ilan talked about. Here again, you see them a little better as you sort of go in with your planes into more of the maxilla, where you see actually the nasal areas right in here inside the nose. Now the maxillary triangle, again, just to show you, is made up of the nasal bones on the top, and maxilla on the side here, and the palate underneath here. And for this to be normal, everything has to be there, the top, the bottom, the sides. If the top is not there, then you're missing nasal bones. If the bottom is not there, then you probably have a cleft. It's a very, very useful view. And then you come up from it a little bit, and you can then identify the upper lip, which really you're in the soft tissue plane now. You've come forward anterior from your rectonasal triangle, and you've got the soft tissues of the lip. These are things that really, they're in close proximity to each other. Just a turn of the transducer will get you all these views as you come in and out of the face from the front and then also from the side. So here, 3D, I think, is extremely important in the first trimester. I can't emphasize this enough. There are things that you see on the surface of the fetus that you will not see in first trimester 2D imaging. I think that it's more important in the first trimester than it is even in the second trimester. The second trimester, you can see quite a bit more detail than in the first trimester. But the surface views of the first trimester are incredibly important. You can see the ear here. Look at the ear developing here at 10 weeks and here at 11 weeks. You see an incredible amount of detail here, again, the ear at 13 and a half weeks. You don't really see this typically as easily with 2D ultrasound. You really have to hunt around for the ears if you want to see them, whereas on 3D, they're just right there once you render your 3D. So let's talk about embryology and some of the anomalies that we can see. To understand how cleft lip and palate works, you have to look at the embryology. The upper lip is made up really of 4 different prominences. You've got 2 medial nasal prominences here in the pink. And then you've got, they form the intramaxillary segment, which you can see down here. And then there are two lateral maxillary prominences in blue that all come together to form the upper lip. So these four prominences have to come together and have to fuse in order to get a normal upper lip. The most common malformation is the paramedian cleft, which is here. It would be this seam right here. So you have, it's not midline, it's usually one side or the other. That's why you can have a bilateral cleft lip and palate or a unilateral cleft lip and palate. On the other hand, there is a type of cleft where the whole middle is missing. Those are the ones that you see in holoprosencephaly, for example, where you have just a big hole. Sometimes you don't even have a nose. Those are basically lack of development of the inner maxillary segment, the whole middle part. And that's probably a different embryologic development of that. So the kinds of clefts that we see are shown here: the unilateral, the bilateral, and the central or midline cleft, which is the one associated with multiple other anomalies, namely trisomy 13, holoprosencephaly, and so forth. Some of these other syndromes here, there's a lot of syndromes associated with cleft lip and palate. Certainly it can be familial. It's called van der Wood syndrome. That's an autosomal dominant syndrome where you have cleft lip and palate, so that can run in families quite readily, because if it's a dominant trait, it'll come down effectively without skipping generations. Hemifacial microsomia or golden horse syndrome, you often have a cleft on one side. You also typically have asymmetry of the mandible, ear tags, things that really pertain to one side of the face more than the other side. Amniotic bands can disrupt the entire face. If you have a band that traverses through the face, you can have disruptions of all different types that really don't lend itself to any description by embryology, because they basically destructive bands rather than lack of a normal embryologic development. Then you have syndromes like EEC, where you have clefting of the hands and feet together with clefting of the face. You can have some of the skeletal dysplasias, in particular short rib polydactyly syndrome type 2, which is Majewski syndrome, is a short rib syndrome, which is obviously a skeletal dysplasia, but if you see a cleft associated with it, then it's Majewski syndrome, it's the type 2. So you can really hone in on the syndrome depending on what else you see along with it. And of course, there are teratogens that can lead to malformations, including facial clefts. So the complete bilateral cleft lip and palate is really the easiest to detect, because the entire intermaxillary segment is off its hinges, if you will, and protrudes forward like a drawer. And so you have like a beak, as displayed here, because the free maxillary segment just moves forward. And so it's easy to spot on a profile view, because you've got this big sort of beak coming forward, which is a combination of the nose and the inner maxillary segment. Now, the most rare of the clefts is that central big hole, which, as I said, is associated with other facial abnormality and intracranial abnormalities. It's usually associated with trisomy 13, holoprosencephaly, hypotelorism, proboscis. You can even have a single nostril, so forth. These clefts are very, very unusual, and they don't really occur unless they're in a syndrome. It's usually associated with some very severe abnormality. And that's a lack of fusion of the medial nasal prominences, the two pink areas on that prior slide. And here's an example of the central cleft. This is a 14-week fetus, where you can see here there's hypertelorism. In this case, the nose is really non-existent, it's flattened, and there's a big central cleft right in the center right here. Now, this was a nuchal translucency brought to me by one of my younger sonographers. And anybody see any problem here? It's a cleft. There's an abnormality here, which catches your eye when you start looking at the nasal bone. And so going in after her, we focused on it a little bit more and found that in fact it was, and these are the ones that protrude forward, so they're really easy to spot on the profile because it forms a flat, if you will. The ones that are really hard to find are the unilateral incomplete, where it's just a lip, and I think those are exceedingly hard to see in the first trimester. So here you can see the lip out here. You can see the beginning of the palate, but then the whole thing here is missing here, and you can see on Alfred's drawing here that it is also similar to what is shown here. Sometimes, and this is a different fetus, you can have a cleft where there's a little bit of palate here, a little bit there, and then there's a big hole in the middle there. That is also a cleft, and of course the palate can have different degrees of involvement. This one, you can see what it looks like in 3D. This is the complete bilateral cleft lip and palate, which is why it was so easy to spot, because it forms that protuberance or that beak. And then in 3D, you can see that there is a seam here and on here, which means that the inner maxillary segment and nose are sort of free, and the cleft is on both sides. And then if you move in with your slices, you can actually identify the actual cleft in the actual palate a little further in, where you can see where the palate actually divides on both sides. Now, sometimes the clefts can be really quite dramatic, and you can see here with the mouth open how you can sort of look up in. If you're lucky enough to have some fluid inside the mouth, you can do a 3D and turn it upside down and look up into the palate and see the actual rent in the palate. And here you can see when the fetus looks up a little bit, you can actually see the normal anatomy here, showing you the maxilla and the pharynx and the soft palate right here and the tongue inside the mouth. If you get those views, you can actually demonstrate the actual cleft in 3D all the way inside the mouth. Now, the Tessier Clefts, how many people here have heard of Tessier Clefts, have seen them? Good. These are very rare. So we have a whole group of experts here who've seen these. These are devastating clefts. They involve the mouth, the cheeks, the eyes, the ears, the forehead, and they are devastating. They occur along the tear duct side of the nose, literally from the lip to the eye. Type 4 and type 5 are the ones that are the lateral aspect of the nose, and they just go up into the eye. And here's an example of, this is one that we had that was older, and this is from the internet showing you what those clefts look like. We have seen a couple of them in the first trimester. Here's one that we saw in the first trimester, and once you've seen these, you can recognize them. They're really easily recognizable because the hole goes up directly from the mouth into the eye. Obviously, amniotic bands can do that too, so that would be the differential diagnosis, something really very destructive. But in this particular case, we never really did see a separate band, and this really qualifies very well for the diagnosis of Tessier cleft. Now, going on to micrognathia, there's another group of syndromes, and as many of you know, I'm big on syndromes, and so I always think of it from the point of view of what else is there that you can sort of put into a syndrome, because isolated micrognathia would tend to be something like a Pierre Robin, which would probably have a cleft palate as well. But then you could be dealing with something much more severe, such as the Joubert syndrome, where you also have a Dandy-Walker abnormality, or Nager syndrome, where you also have a short radius on both sides. So there's lots of different nasty syndromes that can be associated, including all the aneuploidies, obviously, trisomy 18 in particular in this case. And Treacher-Collins is an autosomal dominant syndrome where you can have ear abnormalities as well as a heart defect. So let's see some examples here. Again, courtesy of Alfred, these beautiful pictures. You can draw a line here and find that it sort of the nose, lips, and chin on the other side of the line are actually quite symmetrical and look good. And if you compare that to when you draw the line on somebody with micrognathia, the chin doesn't quite make it on the other side of the line. And he also mentioned the mandibular gap, which is right here seen in normal circumstances. And when there is micrognathia, you do not have a mandibular gap. Here is a small chin, you can see right here. And I think that rather than trying to measure things, I just eyeball it. I mean, this chin looks small. And here you're in the first trimester. If you're not sure, bring them back. But I think that this fetus looks like it has an overbite. And that's basically something that even if you change your orientation and your angle onto the fetus, you will not be able to rectify that. And that's basically how I make the diagnosis. And you can see that we're in the midline. You have to be very careful to be in the midline, because sometimes if you're askew a little bit, you can make it look like micrognathia when it really isn't. So you want to be really, really careful to be right in the midline and have all your landmarks that involve showing that you're in the midline there. So that there's no question. Here's another nuchal translucency. A lot of these come in for nuchal translucencies, and well, this looked a little small. Really, sonographer couldn't make it add up to where it should be along the nose if you draw the line. So we went in and showed that in fact it was micrognathia. Sometimes the micrognathia can be very severe. Here it looks like it's in a bit of a chin tuck, but if you wait until the fetus jumps up a little bit, you'll find that the chin never really advances. And it is much better seen in 3D, is much more dramatic, if you will, if you're wondering if it's real or not. And then of course you see the ear is also low set, which also helps to sort of nail this diagnosis. This is a case of EEC where you can see that not only is there a weird looking face, there was a cleft in here as well as micrognathia and a low set ear, but you can see that there's clefting of the hands here and here. There was also clefting of the feet, so it's sort of like a lobster claw type of hand. This is a case of Nager Syndrome, which we had early on. You can see a very small chin. They have almost absent chins, these fetuses with Nager Syndrome. And the other part of it is the absent radius, or the radial ray abnormality, which is bilateral typically in Nager Syndrome. Now looking at the distance between the eyes, again thanks to Dr. Abu Hamid for these beautiful pictures, you can see that this fetus has hypotelorism, this one has hypertelorism. Again, I don't tend to measure. I guess I'm just not a measuring type. I like to look. And I guess the reason why measuring doesn't help me is because if it looks normal, if it measures abnormal, I'm still going to end up calling it normal. And if it looks abnormal and it measures normal, I'm still going to wonder. So I'm going to end up questioning it anyway. So I rely on my own sort of ability to see if something looks normal or not, which we all have. Now, in fetuses that have trisomy 13 or holoprosencephaly, you can see the monoventricle here, the fused thalami. This is at 13 weeks. You can see the eyes are very close together here, hypotelorism. That's really very common in trisomy 13. Here's another one with holoprosencephaly. This one has a proboscis. And in this case, the two orbits are very close together. They're probably, the two globes are probably in the same orbit, maybe, cyclopia, or at least very close to that. Here's another case of hypotelorism in a fetus with holoprosencephaly. It's usually when you see it. And you have the monoventricle here. And basically you have no nose here because you've got a huge cleft in the middle here, and then the eyes are actually quite close together. So this is really a hallmark. If you can identify an extra digit here, that's going to be trisomy 13 until proven otherwise without any question. Now, how about when the eyes are too far apart? That's sometimes a little harder to spot. We don't see it quite as often. But one syndrome that will display that finding is a triploidy, and you can see in this particular view a very large head and little body. In fact, the head is probably closer to what it should be. The body is tiny, and let's look at this big head, little body here. This is asymmetric IUGR on steroids, basically, in the first trimester, which is very obvious. I've made the mistake to under-measure these and try to reset the gestational age. I've only done that once. I'm not going to do it again because I didn't spot the fact that the head was too big. So always keep that in mind because it'll come back abnormal, obviously, eventually. And these have lots of abnormalities. Obviously, triploidy has lots of abnormalities of just about every organ system, but it does have very typically hypertelorism with the eyes very far apart. You can do a 3D and look at how 3D actually probably makes the findings more dramatic in the first trimester, if you're wondering. This is a very dramatic look at how big that head really is compared to the very scrawny body associated with it. And if you look at the face, it's sort of elf-like because it's of the hypertelorism and the big head, so it looks a little bit elf-like, as you can see. Okay, moving on to amniotic bands. Amniotic bands can involve the face, and when it does, it's devastating because the band just sort of slashes across the face. You can see an example here of amniotic bands. You can see the band coming in here onto the face. It caused a big gash in the middle. Here's one orbit, the other orbit somewhere over here, so that did cause hypertelorism, among other things, obviously, in this particular case. Here's a view of a patient with amniotic bands that was disrupted everything here. Disrupted the anterior abdominal wall, the cranium, and the face. And the best way to see how it disrupted, you see the bands here actually, the best way to see how it disrupted the face is to look at the 3D, and you can see this big gash right in the middle of the face where this thing just ripped everything apart. You know, there's no embryologic way to explain this other than amniotic band. This is a destruction of something that was already forming. So it's you really can't mistake it for anything else, I don't think. Now here was a 12-week fetus that had a very peculiar mass inside its head, and that mass was protruding through the face here. It was a very dramatic look, of course, she came in for her nuchal translucency, obviously. And if you look at the mass, it really is a very echogenic, ugly-looking central mass. And it really protrudes out the face. I mean, at first you might think, well, gee, this is a hemorrhage, but it looked like it was having some destruction in the front of the face here. Let's look at a little bit more detail here. Lots of color, so it's not a bleed. There was lots of color in here, and you can see the face is disrupted here. This is a piece of the tumor coming out here. Again, here you can see how it looked as we scan through. The face is completely destroyed by this tumor. She had a termination of pregnancy, and this proved to be an intracranial teratoma. And you can see how incredibly destructive this tumor was to the face. A talk on the fetal face wouldn't be complete without a talk about duplication abnormalities and conjoined twins. Here is this was actually, interestingly enough, a set of, I guess, twins or triplets, if you want to call it that. There was one singleton out here, and then this fetus here was actually partly duplicated. You can see the two spines here and part of the two brains here, but then everything is fused in here. And then you can see that there's probably 3 orbits. We don't see the middle one very well, but it looks very, very unusual. And here you can see the other fetus over here that was normal. And this just shows you in real time what that looked like. There's also cystic hygroma, and you can see that there's another fetus on the side here. Now, how about measurements? Well, I haven't been big on measurements, obviously, and that's why these are pictures courtesy of Alfred, because I don't do it. But if you do want to make measurements, there are some measurements you can look up with the angles, for example, from the palate to the anterior to the forehead. And you can also measure the nasal bone. I do absent or present typically, but there are a number of measurements you can do, and including the prefrontal area here, which has been associated with Down syndrome. I don't know that. I think this has sort of lost its oomph, this measurement, because of the NIPT and all the things that we now have. Now, as you do your face, you can also consider the other findings that we see here, which in this case would be a normal intracranial translucency, which of course is not here on this one, and this one ended up having a neural tube defect, which interestingly enough we did not see right away on the nuchal translucency pictures. Now, going on to the neck, and I have very little time, so I'm going to go through this very quickly, because the neck is part of what I was assigned to do. And obviously, as you look at the neck, you'll see some abnormalities such as cystic hygromas, encephalocele, tumors, and so forth. And I won't spend any time on nuchal translucency, which we all have been involved with. But you can see that when there is a cystic hygroma, you can also get sort of what we call a spacesuit appearance. This is what I call the spacesuit abnormality, which is basically lymphangiectasia involving the entire body. And you can see that they typically have also big cystic hygromas as well as really involvement of the entire body. This was a Down syndrome. You can see it's missing a nasal bone right here. And you can see that there's a heart abnormality. And in this case, there's AV canal where the regurgitant flow going back, this is the atria here, through the common AV valve going back. Okay, Turner syndrome, usually large cystic hygromas. They tend to have heart abnormalities. In this case, the small aorta you can see here. This is a correlation of the aorta. You can see the relatively large PA here in the aorta right behind it. This is trisomy 18. They usually have cystic hygromas. They tend to have hand abnormalities. Sometimes you can see them early on. In this case, there's sort of a clubbed hand. And then this is a limb body wall defect where you have a cystic hygroma-like abnormality, but the abnormalities are more severe on the lower part. Now, talking about Meckel-Gruber syndrome, this was an 11-week fetus that I saw with Meckel-Gruber syndrome where we made the diagnosis de novo. This patient didn't have a prior history, but you can see the encephalocele right here, which has got some fluid in it, typically with Meckel-Gruber, and then the extra digit. And you can see the cystic kidney right here, which of course, once you figure out what you're dealing with, you can actually piece it together. Here's a younger fetus with the same abnormality, the cystic kidneys, the polydactyly. And 3D really shows you everything all at once. It shows you the encephalocele, the polydactyly, the whole business. Now, this is the earliest case. This turned out to be Meckel-Gruber syndrome when it was tested. This is 10 weeks. You can see the cranium's gone. That's obviously what first caught our eye. Then transvaginally, you get more detail. And the first thing we saw transvaginally was all of these digits here, and on the feet and on the hands. And this ended up testing positive and biochemically, genetically for Meckel-Gruber syndrome. So I'm going to skip through this part because it's covered somewhere else, and just end with the findings that, and this is all in your syllabus if you want to go over it, about the nuchal translucency. We typically do a 3D on fetuses that have died or demised because we really think that there's a lot to learn looking at the surface of this fetus. Now, this fetus is very ground glass. Many fetuses that have passed away have faded, if you will. They're sort of ground glass. You can barely see them. But if you do a 3D, you'll see the abnormalities. And in this case, there was a cleft lip and palate. I am certain. Now, obviously, these are not path proven because you can't get pathology on these. But compare the demised fetus to the normal fetus of the same gestational age, you'll see that there is a rather major hole here that is abnormal. Now, this one was very dramatic. This looked like a completely, this was at about 8 weeks. And this fetus did not have a heartbeat, and you couldn't see any anatomy on it. It was just very ground glass, dead. And when I did the 3D, I noticed that there was proboscis, There's an extra digit here. This was a trisomy 13. There's no way we would have known this without doing this. So I find that this is very, very useful. Here's a Tessier cleft on a dead fetus. Again, very useful to the parents. A lot of times you don't see anything, and I'd say it's a minority of the time when you do see something. But when you do, and you can tell the parents what happened, or maybe have an idea, then that is very, very useful to them. I'm going to end with probably the most dramatic case I've ever seen. This was, we have a set of screens in the reading room where we can see the 6 rooms live, real time. And the sonographers know that if they see something weird, they can put the BB on the screen and I'll come running in if I'm watching, which I usually am. And this was a scan done about, I would say, 10, 15 years ago. And BB was all over the screen, one line and another line of BBs. And so this sonographer was desperate. And this fetus was tooling around. It was for an elevated AFP, I remember that. It was a while ago. And this is what was going on. First of all, the fetus had club feet, I'll give you that. But there was nothing above the cervical spine. The cervical spine ended. The clavicles were here. The fetus was alive, moving around like crazy, but there was no head. I mean, this was not anencephaly. There was no head, nothing. And she went to termination, obviously. And they found in the process of emptying her uterus a sort of a mummified 10-week head. And I guess it had taken its own head off by amniotic bands or something, decapitated itself. And somehow the head had remained, and I think the person who did the termination did a very good job of really emptying everything out and looking. But this was a 10-week head that was still in there, and the fetus remained alive. Don't ask me how that happened. Thank you very much for your attention.